All right. I think we can go ahead and get started. It looks like most of the MPRRAC is on. So Megan, I'll let you take it away from here.
All right. Good morning, everyone, and welcome to our final MPRRAC meeting of 2025. I really appreciate you taking the time to be here and look forward to some robust discussion about how things went this year and our plans for next year. And I think I saw all MPRRAC members, perhaps except one. So I think we're okay to go ahead and call our meeting to order.
Yes, I think we're just missing Chris, so hopefully he can join in 2 minutes. Oh, and he might have just joined right now. All right. Well, thank you, Megan. Yes, welcome everybody to our final MPRRAC meeting of the year. This is our agenda for today. I will also post the PDF link to our agenda in the chat in just a few moments. But today is all about going through the 2025 cycle, seeing ways we can improve going into 2026, as well as looking at the services going into 2026, stakeholder engagement, any announcements, kind of just planning for the future and looking back on this year as well. Next slide. So as always, just these few housekeeping rules. Committee members, if you haven't already, please make sure to add MPRRAC member to your Zoom name so people can identify you as being a member of the MPRRAC. Public stakeholders, we are looking forward to hearing your comments. Please note that we would like to keep them to 2 minutes apiece to make sure that everybody has a chance to speak. The public comment section will be at the end of the meeting today, so it's a little bit different than the setups of the meetings in the past. So just be aware of that. And you do need to sign up in order to make a public comment. So I will be dropping that link in the chat as well as soon as I'm done here. So please make sure to sign up, keep it to 2 minutes as well. Make sure to identify yourself before speaking. Remember, these meetings are for general and broad, purposes. So make sure not to share any protected health information. We will have to scrub that from the video before we're able to post it online. So if it does happen, just kind of takes us some time to fix it before we're able to post it. And then, of course, like always, use the Q&A feature for questions. If you have any, sometimes if we put them in the chat box instead of the Q&A, it can get a little lost. So make sure your questions are being answered. Just make sure to put them in the Q&A feature. Next slide. So Dylan wasn't able to join us today, but as always, the PowerPoint agenda, all the materials for this meeting will undergo ADA remediation after this meeting. And the reason for that is because they often change very, frequently up until the meeting. So it's hard to remediate them before the meeting. So just know they'll be reposted online always within a week of the meeting, and they will be remediated in that way. Thank you. And if you have any questions about that, you can contact Dylan. If you could go back one slide, please, Kevin. Thank you. And his contact information is right there if you have any questions about that process. Next slide. All right, so just some special announcements. Unfortunately, we are losing one of our members, Terry. So she will be retiring from the committee after this meeting. We can't thank you enough, Terry. You've been very valuable to this process. So thank you so much for all your work. We'll really miss you. And we'll post that opening on our website after this meeting, probably by the end of November. So if you know of anybody who might be interested, send them to our website. That will have all of the information on, who qualifies and how to apply. And again, thank you, Terry. We do have a new HICPUF employee. His name is Cole, and I'll let him introduce himself.
Right. Thanks, Michelle. Hi, everybody. My name is Cole Hoffman. I started as a rate review analyst last week, so I'm coming up on the end of my second week on the job. Thanks for having me here today. I look forward to meeting you all and working closely with you all.
Thank you, Cole. And lastly, we do have our 2025 MPRRAC report available. It's on our website. Sorry, you see my cat in the background being the most. So I'll post that link to the report as well. There are a lot of appendices, so I'm not going to post each link to the appendices. So I'll just direct you guys in the right direction to find all of that information, but it is available on our website. All right, next slide. We do have the upcoming JBC MPRRAC presentation that will take place on November 18th from 9 to 10 is when Megan, our wonderful chair, will be presenting. And then from 10 to 10:30, which will be the HICPA portion of that presentation. This meeting is really just for the chair to discuss, how the process went overall, the recommendations that were put forth to the JBC, strategies, methodologies, all of the above. It will take place virtually, so if you're interested in listening in, there is a link to the JBC schedule, which will take you to their website. On the day of, you just click listen, and you can hear the meeting going on. So thank you, Megan, for handling that. And then I did send a link to all the MPRRAC members as well to listen in a calendar invite just to get it on your calendars. All right. I'll hand it over to you, Brian.
Yeah, thanks, Michelle. Good morning, everybody. Brian Poole with GPS. I'll be facilitating today. And as always, we'll just do a quick review of our rules of governance and just get us started. This has always been a key element of our work here together, and that is that the MPRRAC committee members and particularly our chairs operate on a premise of self-governance, and we continue to make wonderful strides in that direction. It's really been a pleasure working with everyone. And we'll obviously maintain a respectful and safe environment for everyone, make sure that just one person's speaking, and everybody please stay on mute. We'll be tough on the problems facing our state and easy on each other as we work through this. And we've seen everyone come prepared and reviewed all the materials in advance. So again, we're doing really well on all of these rules as we move forward. Just a reminder that we do have terms for our chair and vice chair. These are one-year terms, and as agreed last year in this meeting, the vice chair from a year will then be promoted, if you will, to chair in the subsequent year. So we're about to work through that, and then we'll have a process to make sure that in this meeting, in the November meeting, that we decide on the new vice chair, and they'll have a year to sort of see how this operates from behind the scenes, and then step forward into that chair role. Just some important reminders for today, maybe even particularly. The MPRRAC is a legislatively appointed body that functions collaboratively with the department, but our members are not department staff. And the rate review staff is tasked with synthesizing all the actuarial analysis into really digestible reports and slides like we see here, and works with other staff to develop the recommendations for rate or policy changes, which are then ultimately agreed upon by the MPRRAC. Now, the recommendations may result in future budget actions by the department, but all rate changes must be approved and appropriated by our state legislative body, which is always the case. So just a reminder this year. And then a review of services includes analysis and recommendation, but does not guarantee any of the rate changes that would be recommended, either increased or decreased, or even changes to policies. As always, we have a sort of a four meeting structure throughout the year. In March, we shared the preliminary data analysis on rates. Our June and July meetings, where we really get into the details, discussing the very detailed analyses and get recommendations from the committee on those, and begin the process of planning for the following year. In August, we do finalize all those recommendations and get the fiscal impact analysis of that. That was our last meeting. And then today is really our lessons learned and doing our annual training, making sure our planning discussions happen in advance of the winter effectively. And then we review some of the off-cycle requests, if any, or schedule changes, and again, complete our training, and we will do that vote for our vice chair. So just specifically today, our goal is to really brainstorm ideas to improve the process for next year. And so as we think about that, what are the areas of analysis? What are the details that we need to see? Just our process and how we work together. All of that is subject for good discussion. And we've had a long history here of making incremental changes each time that have us working better and more efficiently together. So I would expect that to continue. That vote for vice chair will occur today as well. We've got some deep trainings and resources, and we've got time for public comments, as Michelle mentioned, right at the end. All right, I'll hand it off to Ian for meeting minutes.
Great, thanks, Brian. Before I get to the minutes, I wanted to call out Michelle that I saw one of the AI note takers. I just want to make sure that I think we said we kicked those out, right? I can't remember if that's the case, but so can we kick it out?
I think our stance is just like it's hard for us to stop. And Kevin Martin, correct me if I'm wrong, but it's hard for us to stop that, but we do urge the public to use the notes posted on our website.
Yes.
For the most accurate depiction of what happened here in the meetings. As we all know, AI can sometimes get it wrong. So if you're using AI notes, just know that the official meeting notes are going to be posted on our website. Those are going to be your most accurate ones.
Okay, that sounds good. All right, are there any questions or are there any comments from any of the MPRRAC members on the meeting minutes from the August 22nd meeting? All right, I will motion to approve the minutes from the August 22nd meeting.
This is Tim. Move to approve.
All in favor?
Aye.
Can we get one more?
Yeah, approve.
Okay, great. All right, minutes are approved, and I will pass back to Brian.
Yes. All right. So as we think about part of our purpose for today is to look ahead into 2026. So let's just peek into the calendar for next year. We have our review and selection updates here. We have the impact of the TPL and copayment on benchmark ratio calculations, outlier analysis, our benchmark review methodology, access to care metrics for 2026, and the actual analyses for next year. So this is a little small for some of us, but these are the service categories that are under review for next year. So you can see we start with anesthesia, ambulatory surgical centers, then we move into our behavioral health services, just the fee-for-service group, then maternity services, abortion, pediatric behavioral therapy, dental, and our surgery group as well. So there have been some updates here, and our surgery during prep for the 2026 surgery review, the department found some codes were overlapping with those reviewed under the physician services in 2025. So moving those overlapping codes from physician services in 2025 out to surgery 2026 for reevaluation. This will ensure a more accurate code classification by the service type and make sure all the codes are reviewed in each appropriate cycle. And particular categories impacted here this time are gynecology and radiology. I think I'm getting help on this one. Is that right, Wei?
I do not think so, actually. I think mine is the slide 18, the TPL stuff.
Okay, thank you. All right, so dental updates. We have data sources here that we want to reference. We received some ad hoc data sets from DentaQuest. These contain some unclear claim and claim line status values and provided only upon request and missing some of those key elements. We've accessed the invoice data tables that are updated weekly with the DQ data. Those are regularly updated and refreshed weekly, in fact, and used for the invoicing. So they expected to have a higher accuracy. And we've also prepared, these are also prepared by DQ, which is going to ensure consistency in the data origin. Now, for comparison results, we have the paid amount and the claim count match rates exceeding 97% between the two sources. And so with the decision moving forward, well, we will proceed with the invoice table data for the analysis to ensure the higher accuracy and efficiency levels.
Just a question here. Has this topic come up? I know, Michelle, you mentioned doing the dental like work groups. Has this topic come up at all? And have we gotten any feedback from the community around this?
Regarding the dental work groups?
Yeah.
Yeah, and we do have a slide on the work groups later on. But yes, we have gotten some feedback, right, Wei?
Yes, we did.
Okay.
For our nurse home visitor program in 2026, we've reviewed for the first time we'll review that in the maternity service category. The NHVP provides services to first-time pregnant people whose first child is less than 1 month old. There are some targeted case management rates here, T 1017 with HD and TD, and then G 0006 HDTD. These current fee-for-service rates are provider-specific, making their review difficult. So to address this, the average of the provider-specific rates will be used as the baseline in the review. Okay, I'll hand it off to you, Wei, now.
Thank you, Brian. Yeah. Okay. This slides introduce how TPL, the third-party liability, and copay amounts affect the benchmark ratio calculations. So the formula here shows how benchmark ratio is calculated. So we start by taking the Colorado fee-for-service repriced amount and subtracting any TPL and member copayments. So we are only looking at what Medicaid actually pays. Then we divided that by the benchmark rate payment for the same service and adjust for TPL and copays. So the result tells us how our rate line up. So a rate of 1.0 means we pay about the same. And if the rate is above 1.0 means Colorado Medicaid pays more. And if below 1.0 means we pay less. So when TPL and copay amounts make up a large share of the total repriced amount, the benchmark ratio becomes distorted. So either inflated or deflated, depending on the direction of the rate comparison. So our goal here is to identify a reasonable threshold for when these amounts should be excluded from the calculation to ensure accuracy. Next slide, please. So this example shows cases when Colorado Medicaid rates are higher than benchmark rates. So in the first row, one assumed the TPL copay being very high, like more than 90% of the Colorado repriced amount, the benchmark ratio becomes negative, which is not meaningful in practice. So in the second row, when TPL copay is completely removed, the ratio aligns with the rate-only comparison, so approximately 114%, indicating Colorado Medicaid rate is higher than the benchmark rate. So in the next 6 rows, as TPL copay amounts increase, the benchmark ratio rises significantly, showing how sensitive the calculation is to high TPL copay values. So when TPL copay amounts exceed 40% of the Colorado repriced amount, the benchmark ratio increased by more than 10 percentage points compared to the rate-only ratio. I will give you a little bit time to look at the chart here. Okay, next slide, please. So in contrast, this example shows cases where Colorado Medicaid rates are lower than benchmark rates. So again, the first row with an assumed TPL copay amounts equal to about 51% of the Colorado repriced amount. The benchmark ratio is at 66%, indicating that Colorado's payment appears much lower than the benchmark once high TPL copay is factored in. And in the second row, when there is no TPL copay, the benchmark ratio is 80%, which reflects a true rate-only comparison. So Colorado's Medicaid rate is at about 80% of the benchmark rate. So in the remaining rows, as the TPL copay amounts increases, the benchmark ratio consistently decreases, showing how sensitive the ratio is to rising TPL copay levels. So for example, when TPL copay reaches 40% or more of the repriced amount, the benchmark ratio falls by 10% percentage points or more compared to the rate-only benchmark. So this example illustrates that higher TPL copay assumptions can artificially deflate the benchmark ratio when Colorado's rate is already below the benchmark rate, so potentially overstating the difference between the two. I'll give you a little bit of time to look at the numbers here.
I guess a question for clarification.
Okay.
The TPL copay amounts, is that this in the equation you showed on the prior slide? Is that the same number that's being subtracted from the Colorado rate and the benchmark rate, or are those two different numbers?
Okay.
Like if the liability insurance is different in the state?
It is the same amount we use.
Okay.
Yeah. Okay, next slides, please. Okay, so first let's summarize the issue we identified. So high TPL and copay amounts can significantly distort benchmark ratio results. So when these amounts represent a large portion of the repriced dollars, the ratio becomes less meaningful and no longer reflects a fair rate comparison between Colorado Medicaid and the benchmark rate. So this brings us to the proposed threshold. So we suggest setting a 30% cutoff for TPL and copay as a share of the repriced amount. So when TPL and copay exceeds 30%, we would exclude those amounts from the benchmark ratio calculation. Instead, we would apply a rate-only benchmark ratio for those high-impact cases. And this adjustment would help reduce variation in the benchmark ratios, ensuring that large TPL or copay amounts don't skew the comparison. And it also improves the accuracy, consistency, and fairness of how we evaluate rate alignment between Colorado Medicaid rate and the benchmark rates. So finally, we would like to hear your feedback on this proposed approach, particularly whether the 30% threshold feels reasonable. And if it's helpful, we can go back to the slides with the numbers so you can see the difference between, one exceeds like 30%. So we can tell the impact on the, because there is, after the, when the rate is like 40%, it will have a 10% percentage points difference.
I have just like a conceptual question / comment. Can you go back one more slide? Sorry, one more slide. This one, yes. So, and this is what we're doing already today. Is that what y'all are saying? Like this equation and the first sub bullet, this is how the numbers are calculated today. Because I'm wondering why we subtract out the TPL and copayment amount from the numerator and the denominator. Like I would think that we're trying to kind of compare Colorado services to the benchmark, and that my instinct is we should be doing a rate to rate comparison, like the Colorado fee for service versus the benchmark, and it should be like a rate to rate comparison. Like that's really to answer the question of how does the rate compare? Is it too high? Is it too low? And like why are we subtracting out the TPL and copayment amount in the first place?
Our benchmark ratio, I mean, this decision was made before I joined the team, but our benchmark ratio is actually we're looking at actually Medicaid paid amount, not purely the rate difference. And so when we look at the paid amount, we subtract the TPL and the co-payments. As you know, like if you go to a service, like if the rate is, $100 for this service and you have a TPL or copay $20, and the Medicaid will only pay $80, will not pay $100. So we used $80 to compare with if it's not our Medicaid rate, if it is benchmark rate, what would the payment would be for us if our rate is the benchmark rate.
Okay.
Yeah.
And ultimately, is that what helps with the fiscal impact, or is it really I think I have a similar question of how that really helps us to compare what we're paying as compared to other states.
Okay, so for the fiscal impact is what's the difference between the two different rates on this service, right? So the TPL remains copayment remains the same. So it's basically the fiscal impact is the rate difference for this code times the utilization. So the TPL, it doesn't matter here because the TPL shows in both places and you just cancel out. Lili?
Yes. Yeah. I want to add one point is for a service, for example, for vision, they have more than 100 code. If you don't have the utilization data and the TPL data, you only do the rate only comparison. You only get the benchmark ratio for each code. You can't get an aggregate benchmark ratio number for the whole service if you don't have the utilization data attached. And as Wei mentioned, we care about what actually Colorado Medicaid paid, not only the pure the rate to rate.
Okay.
I hope we answer your question. Yeah.
And we're definitely open. I mean, that's part of what this discussion is about. We're open to, altering that if you prefer to see it differently, or I mean, one of the things we've done in the past is just throw out all the claims with TPL. That works. That works reasonably well for the majority of services, but then there's going to be a couple that have a lot of other payer information. And then you significantly reduce your sample size of claims that you're looking at. So it's just different ways of working on it or presenting it.
I guess perhaps just practically for us. So if we said that methodology makes sense in the upcoming year when we're seeing rate comparisons, there become sort of three subcategories, or is this still get lumped into these were codes that had benchmarks and these were codes that did not have benchmarks? Because we've sort of had like categories within categories, right? Codes that are benchmarked to Medicare, codes that are benchmarked to something else. And this seems like you would end up with, codes with a benchmark that the TPL was included and codes with the benchmark that the TPL was not included. And so I'm just trying to understand that maybe from a complexity perspective.
Okay, so we haven't decided on that part yet, but I think the codes impacted by this situation is limited. So, so I think if there's only like a couple of out of hundreds of thousands of codes impacted, then it may not be necessary to separate them out from the results presentation, right? Yeah. So, but if there is a huge amount of the codes gonna get impacted, then we probably can present them separately. Yeah.
Or even in the like appendix Excels that you all have been creating where we get to the code level, could you just add a column that has like an asterisk or some marker that shows if you applied this methodology, just so we can see when it's being done?
Yes,
My
definitely.
main reaction is I'm not sure, and I'm not an actuary, so I don't know, and I'm not like for or against it. I think we'd probably, in my opinion, we'd trust your all's judgment on this, and then just provide the visibility and transparency when you do apply the methodology, so that the committee can see when that's being done. I don't know, Megan, if you have any other thoughts or others.
Yeah, I mean, I tend to agree with that, but interested if others have thoughts or comments.
My only thought, and I don't even know how to say it, is it a true comparison to whatever the benchmark is? Like if we're benchmarking a group of states, and we're subtracting the TPL copayment, but is their basic benchmark the same as ours? I guess is what if it's not rate to rate. And I get why it's not, but it's just a different way of thinking in my head. So is it a true benchmark? And is that part of why sometimes the public feels like the rates aren't accurate because we've made adjustments?
So I take it your question is more for the formula, right? It's like, should we take the TPL copy out or not?
Yeah. And it might just take a season of getting used to how it looks when the information comes to us to look at.
Okay, Kim?
I'm not sure if this will be helpful or not, but this is a kind of rare situation. Like last year, in the lab and path category, we had over 1,500 codes, and then there was only one that had like a high level of TPL and copay compared to the total repriced amount. And if it kind of also helps, when we look at our overall benchmark ratio, what we're doing is we're looking at what our estimation of what Colorado would have paid if we're reimbursing at the most current Colorado rate versus what would have been paid if we were reimbursing using the same utilization and TPL as in Colorado at whatever the benchmark rate would have been. So that's what's being shared in that calculation. So if that's helpful at all to let you know how often this is going to be a situation, but the fact that it can happen is why we want to talk about this a bit more. So thank you.
Yeah. So let's look at this slide right now here. So when we don't consider TPL copay, which is the second row, the green row here, and that's the benchmark ratio for rate only, right? Because there is no TPL considered in this example. So 80%, that's the percentage benchmark ratio. And if the TPL and copay is 5% of the repriced amount in this case, then the ratio changed to 79.1%. So at this point, the difference between 80% and 79.1% isn't big, right? So when the impact on TPL is not as much before like the 30% hits. After that it changes faster. So also give you a hint of how TPL copay we use to impact the rate only ratio like you were originally thinking of. And so this is one example. And if we go up another slide. Yeah. So you can see in this case, 5% the TPL, 5% of the reprice amount, if it's the TPL, then it increased by 1% of the benchmark ratio. But then once it hits 30%, then the change is getting more dramatic.
Are we needing to make a vote on like accepting this recommendation versus not?
If I think that would be helpful.
Okay. Is there any further questions or discussion on this topic? Not.
Sorry, I'm still processing it, Megan,
Yeah,
honestly.
sure.
I think there's a difference for me at the individual code level versus at like the full service level. Like Ling Ling, I understand your point at the full service level that you need to ultimately calculate the fiscal impact, you need to run across the full service. Like that makes sense to me. But like at the individual code level, it makes less sense to me. Like if this slide here were an individual service code in any therapy service that we've reviewed, I think the correct data to look at would be 113.7%. And TPL and copayment is I agree it has fiscal impact, but in terms of like the sustainability of the rate, whether too high or too low, it's like the green row, it's the rate to rate comparison. So that's where I'm my instinct is that we should for code level we should be doing rate to rate comparisons, and I know y'all need to calculate the fiscal impact, that's very important, and but we can do that at the full like service level, but I'm honestly still processing it, and if I'm misunderstanding, please let me know.
I think another point is when we do the service level, we can't want to be consistent as the code level. If you use something different for the service level than from the code level, it introduces some discrepancies, inconsistencies. Okay, I think Tim has his hands raised.
Tim, if you're talking.
Thank you. I was just going to my unmute button there. So I'm just really trying to understand what the problem is. So let's just say we agree on an amount and it is accepted and it's budgeted, and co-payments are payments that patients pay in relationship to the total amount of what the benchmark rate is. So if HCPUF pays its amount and the patient pays the copay, then are we paying, or is there more money that's being paid out than what the benchmark rate is? Or between the benchmark rate that Medicaid pays and the copayment, then that's the full payment? Because I think that also has implications on how do providers, are patients actually paying their copay amounts? I don't know if that made any sense or not, but I guess I'm still trying to understand exactly what it is we're trying to approve here. Thank you.
I mean, I feel like what we're seeing is that, you know, this has been the existing methodology that we've seen so far when we're comparing rates. And there are a few codes that have a relatively high TPL and copayment. And so when they are already above the benchmark, it sort of skews to one extreme, and when kind of like makes them look even higher. And when they're below the benchmark and that proportion is high enough, then it makes them look that much lower than the benchmark. I mean, I think probably the most important thing is to pick a methodology and stay consistent. I think that this is, like, for me, a reasonable rationale to give a try, especially if it's a very small number of codes. But yeah, I mean, I think whatever we do, every methodology is probably going to have its set of imperfections, like just choosing something and making sure that we're being consistent year after year. Other thoughts, other questions?
I'm okay with that as long as if we do believe it's fairly rare, to Kim's point, and then if the department can provide just like visibility when it was applied, I think that's fine.
I agree that consistency is important.
So would you like to move forward for a vote to agree with the 30% of threshold? It's kind of less than 1% of the code has this extreme situation. We want to improve our method, but we want to keep the consistency.
Okay. Is there a motion to accept this recommendation or alternate?
So moved.
Okay.
And I'll second it.
Great. Any opposed? Okay. I think hearing none, we can go ahead and accept the recommendation to remove the TPL and copay for those codes that are where the amount is over 30%.
Thank you. I will pass the next slide to Kim, I think.
Yes, so we're gonna throw another analysis heavy slide at you all while we're on the topic. This one I want to introduce an outlier analysis method. So this method is something that can be applied when we're using other states for comparison. And this method is a way we can exclude outliers at an individual code level. So a standard statistical practice. It's pretty easy to look it up on Google or in any statistics website, textbook, Khan Academy. But you can look up the 1.5 times the interquartile range rule. So this rule, when you have data that's potentially being skewed or where the mean could be skewed by an outlier, this method basically sets up a lower bound and an upper bound. And anything below the lower bound, above the upper bound, is considered an outlier and should probably be excluded from the data. So essentially, the math is for the lower bound, you find the interquartile range first. So that's going to be Q3, which is the 75th percentile, minus Q1, the 25th percentile. And then you multiply that range by 1.5. So it's a little bit bigger. And for the lower bound, you subtract that from the first quartile. And for the upper bound, you add that to the third quartile. And that sets a lower and an upper bound to define when there is an outlier. So here is some artificial data, code 1, 2, 3, and 4, with states A, B, C, D, E, F, and G, and some very made up values to kind of demonstrate what this type of methodology would look like. So I want to jump first and talk a little bit about code 1. If you notice, I bolded the value 37 under state E. That is a higher value than a lot of these others. But if we use this process, despite the 37 seeming like it is a bit higher than others, it is still within this upper bound. Our upper bound is 37.25. So that would still be a reasonable value with that set of data. But when we look at code 2, I threw in a very unreasonable value. If we were to look at all these rates for code 2, we're looking at things from 83 to 94. And you would expect that average to probably be right around upper 80s, other than this 527 that's thrown in there. It's hard because we're looking at a lot of other states, and sometimes there are a lot of codes, and sometimes it's hard to be an expert at what's going on in another state. But that stands out as something that does not seem like it matches all the others. There might be something going on in that other state. Maybe the policy is different. So this outlier analysis gives us a way to identify codes like that, particularly when we're looking at a service category with hundreds of codes where this is more difficult to catch otherwise. So this 527 is far above our upper bound here of 106.5. So that would be excluded from the data. And what this does is it helps us with the average, the mean. If we leave it in, our mean is somewhere around 150, which is very different from our other measures of central tendency. Whereas if we were to exclude that, our mean falls more around 87, which is more in line with what is expected for code 2. Code 3 and 4 are kind of thrown in there to show some of the other ends. So in code 3, we have some 14s and 15s, which is pretty common value in that set. There's a 12, which seems pretty low, and a 17. Neither of those using this method are outliers because they are within this 11.25 and 17.25 lower and upper bound. On the completely other end, in code 4, we have values in the 40s and low 50s. So we would expect this particular code to be right in the 40s or low 50s. if we throw this 14 in here is way different. Something strange could be going on in state C for code 4. So this outlier analysis identifies 14 as an outlier. And so that value would be excluded. And that would mean our average, if we leave it in, it would be right at 43, which is kind of pretty low. Whereas if we were to throw this outlier out, we're looking more at 49, which is more in line with what we would expect given the other states here. So that is our method for outlier analysis. And I want to open this up to you guys if you have any questions about this process.
I guess just this is one that is currently being used, or this is also something that is being proposed for the future?
We want to use this consistently through cycle 2. This has been used in situations where outliers have been identified, but we want to build this into our workbooks and make sure in cycle 3 we're consistently using this. And so I want to make sure, Ling, do we need a vote on this one as well?
I'm fine. Megan, do you want to vote?
Yeah, I think if this constitutes a change, we might as well vote on it. Are there any questions or discussions on this recommendation?
It makes sense to have a consistent approach to looking at outliers.
Yeah, and the methodology is well accepted. It's not anything, creative.
I guess my concern is that we're taking a tiny sample of the actual sample. So basically, like, the real sample we should be taking is a 50-state comparison, so 49 states versus Colorado. So we already dramatically narrow the sample by only picking 7 states. Then we further cut a tiny sample. So if we were doing a 50-state analysis, I think a 1.5 times the interquartile range would be totally appropriate. I don't think it's appropriate for a subsample. This is a tiny sample that we're striking from. And so and then there's other ways to deal with this. You can take a median, you can take a trimmed mean. It feels, because it's such a small sample that we're taking, we're like removing data, which is like harming, not helping us. Does that make sense?
Yeah, I mean, I definitely understand that point. I think the question would be, is there an alternate methodology that would be recommended to use consistently, as opposed to, say, ending up in each situation and then trying to decide which methodology to apply to this situation? Again, I think, in my view, the consistency would be helpful. I definitely hear the concern about starting from an already limited sample. I wonder, would it be helpful to know more about how often this sort of situation comes up?
That would be very helpful, yeah.
I think it's rare too. It's not very often, but maybe a little bit higher than that TPL on the copay situation. That one's more extreme.
Yeah, this is sort of coming out of that whole issue that we had with Nebraska and the PBT rates a couple of years ago. We just need to have some kind of formalized process, and in addressing some of the things that you were mentioning there, is that this is actually a well accepted methodology for small sample sets. So using a median is not great, because if you happen to have, say, like, I don't know, looking at the sample set, we have 7 of them. And if we just look at, say, code 4, the median there would be 1, 2, 3, 4 would be 49. Whereas the that would be quite a bit higher than an actual average with taking out the outliers there. So, but it could also go the other way because a median is just picking the number in the middle. So if that middle number happens to be just on the low end of the difference between the second to middle number on the low end and the second to higher number on the high end, it can be within a wide range, and it just is whatever it happens to be within that range. So a median is not necessarily a good way of selecting one. It's also not great to use something like a standard deviation approach because we are using a small sample. Because standard deviation really works better for just large samples in general. You need a larger sample in order to sort of make a normal curve. And then I guess the last point there is that we're almost required to use small samples because there are lots of situations to throw out other states because they're not similar, because they use mostly managed care, because they don't post their rates at all. And so there's not really a way that we can even do a full 50 state comparison. We could potentially do a few more states. It's just, that's also a significant effort. Every time we go and do this selection of states, sort of by evidence of the 7 2-hour stakeholder meetings we had for 2 service categories just to figure that out for this coming year.
One other further comment, Kevin, on the median part. We're not looking to throw out lots of outliers. We're looking to catch things that are very different than the other data. So generally when you use the median, so like the z-score, which is based off the standard deviation and the median, that's generally when you're dealing with normally distributed data and you want to trim the tails of that data when the tails are really long on either end. In our case, like for code 2, the difference here is that now the median is at 150, which skews that it's no longer normally distributed. And so you don't use, so in standard statistical practice, you wouldn't use for skewed data the median here because the median is going to skew that z-score and the standard, when you do that calculation. And then when you look here at code 4, as Kevin mentioned, the median here, we're looking right at 49. If we get rid of the 14, our mean aligns with the median right around 49. I think it's 48.5. So that's, really close together. Whereas if we left that 14 in there, our median all of a sudden is 43, about. And so that's a lot lower than our other central measure of central tendency here. So using some of these other outlier methods, they're generally geared towards normally distributed data. And that's definitely not the situation that we're viewing here. If that helps a little bit.
Ling?
Usually we try our best to have a 10 benchmark standards, but we can't guarantee. Like if the provider community and the policy people have good suggestion, we usually have 10, like a PPT. So it's not too small, but 50 usually is not very realistic. Yeah, you know, you need to research all 50 states, and many of them you can't get the information easily. So, yeah.
Yeah, and Ling, please don't interpret my comment that y'all should do 50 states for every service code. I'm not suggesting that. Um, I'm supportive of the concept of doing an outlier analysis. I'm more questioning the 1.5 times interquartile range methodology for a tiny subsample, which I don't think is consistent with general good statistical practice. Like if the like for example, code 2, if this were 107 and not 527, we would exclude that from the methodology, even though I think in a 50 state sample, 107 should be a data point that should go to extrapolate the mean for the full 50 state sample. So it's like what is the right methodology to determine what is an outlier, and 1.5 times interquartile range for a tiny 7-state sample feels too narrow to me when we're already not. I think that would be very reasonable for a 50-state sample. For a 7-state sample, it feels narrow to me and risks both on the high side or on the low side excluding data points that would be helpful for the committee to pick the right rate for to benchmark against.
Thank you.
I mean, yeah, we can what if this a lot. If we pick something that is, you know, right on the border of the quartile range, yeah, selecting more states could easily like bring that in. But that's not usually what we're talking about with outliers. Like this 527 is actually sort of representative of what we see when we go and look at these. When we find outliers, they're pretty extreme.
I mean, I think as with the last one, there was sort of an ask to maybe highlight or asterisk when the methodology had been applied. And I suppose that could be an ask as well, just to highlight when that had been applied and like potentially just not necessarily that it's part of the presentation, but available for reference, like how much it sort of skews the information to include the outlier versus have it excluded.
Yes, we can add it.
Any other discussion on this? And so I think we've heard some like in support and some in opposition. Is there a motion? Can we get a motion to accept or?
Sorry,
I'll try. Let me try. So I'd be supportive of this if we do the 1.5 interquartile range. If you all can provide another flag, just like another column in the Excel when this is applied, and that the committee has the right to basically like review and provide feedback if we are excluding it at the code level. And if this is some teensy tiny code that doesn't really impact things, of course, we're not going to like pay attention to it. And then if there is a meaningful code that truly impacts the service, it would be up to the committee to review and discuss, as we do already in our state benchmarking approach. Would that be reasonable to folks?
Yes, I'm fine with that. We can provide for that accommodation.
Okay, great.
Yeah, I think that sounds like a good suggestion.
Great. Well, then, all in favor of the motion as Ian stated?
Aye.
Great.
Aye.
And then
Aye.
any opposed? Perfect. Great. Thank you. Motion passes.
Well, thank you. I'll pass it back to Brian.
Yeah, thanks, Megan. Good work. All right, so along this line, this is sort of part of our overall training as we work through today. Just some reminders, right? The Medicare benchmark is the primary comparator wherever available. So we've seen that over and over again. In the cases where there is no appropriate Medicare benchmark, we will identify comparable state Medicaid rates in collaboration with the stakeholders. So that's sort of how you get to the 7 states that we saw on the previous slide. Now, in some cases, there are commercial rates that may be applicable, and yet there's a few things to consider with these. Number one, we would consider reliable, publicly available commercial rates when there's no appropriate Medicare benchmark exists, the data quality is seen as high and comparable, where internal and external stakeholders would support that approach, and a dual benchmark, for example, other states' Medicaid plus commercial, is appropriate. So some limitations on when to use commercial rates there. And then, as always, right, whatever the final rate recommendations are, whether commercial or not, these would be incorporated and reflected, and ultimately subject to the JBC's approval.
Hey,
Kevin speak. Thanks, Kevin. Go ahead.
Thank you, Brian. I'll be taking this slide going over our proposals for the access to care metrics in 2026. So as you can see, there are some that might look familiar, few that might look a little bit more new. To start off, panel size, as a reminder, looks at average number of utilizers per provider for a service category. We typically look at a trend over the period across rural and urban regions, as well as a map breakout by county in the most recent fiscal year. For provider participation, that one looks at the percentage of providers in Colorado serving Medicaid members in a given service category among all providers in that service category. Penetration rate, that one with an adjustment would look at the percent change of Colorado Medicaid members who utilized the service over the period. Drive times, the percent of members that lived in a certain drive time bands, and the time in minutes it takes to reach a provider. So those bands could be 0 to 30 minutes, 30 to 45 minutes, 45 to 60 minutes, and over an hour. One of the newer metrics that we wanted to propose is something that we're considering as continuity of care. That would be sort of a 3-component metric looking at entry rates, which would be the percent of active Medicaid providers during the period that served Medicaid members who had not in the previous year or years by service category. Exit rates, the percent of active Medicaid providers who served Medicaid members in 1 year but did not in the following year or years. Provider stability, the percent of providers in a service category who stayed active over the entire period. And our thought process behind this is it would help us get an idea of providers that are coming, going, and staying. We considered looking at this on a statewide basis. For the next two, those ones might look familiar too. We did those in 2025. Per member per year, expenditures and utilization. Specifically, a member in this context would be considered a utilizer of the service. So starting with expenditures, that would be the average total expenditure per utilizers per year, sometimes month, depending on the category over the period, looking at a trend. And then for utilization, that would be the average total utilization per utilizer per year for a service category over the period by payer. That being said, I'd like to open it up to any comments, questions, feedback before we hand it back to Brian.
I have a question with respect to the continuity of care. Would we see those as 3 separate lines, or is it somehow aggregated as a composite measure?
No, I don't think we would aggregate it as a composite measure. I think that we would kind of section it out so they're side by side so we could see those Medicaid providers that were coming, going, and staying. So while it is kind of considered three pieces, they would all belong to kind of a general metric that each constituent part would lend to helping us understand the overall picture of provider continuity of care and their availability for the Medicaid network.
Thanks for that.
Mm-hmm.
This is Tim. When we're looking at drive times, what metrics are you using for drive times?
Yeah, so
I guess I'll expand upon the question. Is it like a Medicaid client to a provider? Or is it, in some cases, the provider drive times to the Medicaid client?
Yeah, that's a good question because there are certainly instances where a provider might be the one going to the client. I think that was the case last year with some of the targeted case management services. But in general, our focus of this metric would be the time it takes the member in a given area to reach, say, the nearest provider, the average of that, and then we look at like the percentage of those members across the state which live within certain bands in order to get an idea of what parts of the state might have longer distances to reach a provider. We're able to usually look at that in the most recent fiscal year, sometimes averaged over the period.
So is it possible for HCPUF to get, for those providers that go to clients, how difficult is it for HCPUF to get that data? Because that has implications on access to care. For example, home health, private duty nursing, EMS, and when we think about applying those metrics consistently and reliably, and increase the validity of that information, how difficult is it for you to do that for those specific cases?
Yeah, I don't think it is particularly difficult because it's just sort of the reverse of the way we usually do things. I think that it would depend on the services under review. If there are any services this year where that might be the case, I think in most instances, our services have the member going to the provider. But for like future instances where we review EMS, things like that, and those situations where providers are visiting the patient's home, I think we could talk about that when those services are under review, see if it's a good fit.
Okay, thank you.
Yeah.
Any other discussion?
If not, we can hand it back to Brian. He'll initiate the discussion. Yeah.
Yeah, I'd ask Megan, are there is there a discussion that you'd like to see with the committee? And if so, would you vote to approve these as the sort of the standard metrics that we would expect to see in starting in March?
Yeah, I mean, I would love to know how our members felt about the information that we had this year in terms of access to care metrics, and if there was any thoughts about adding those continuity of care metrics. Did we feel like we had everything that we needed? Did we feel like there were things that were missing that we might also want to think about including?
So when we think to access to care and continuity, when we think of access to care, are we also thinking about non-traditional sources that could provide that care as well? Such as community integrated health agencies providing some of that care.
Yeah, I mean, I think we've had some of that discussion within the code areas that are relevant. I think this individual data we've sort of had specific to like code sets. So I don't know how much it applies to think about like other services that would apply or provide similar service to another service that we're looking at. I don't know if I'm making that statement clearly. Like, I don't know that we've really had discussions about alternatives to a service that we're reviewing at that moment.
Last year on our access to care metrics list, we also had telemedicine accessibility listed. Is that important for this year? I don't know if any of those behavioral health things are able to be done by telemedicine or.
Yeah. For behavioral health, that one's kind of a tricky service because the majority of services are provided under capitation in Colorado. So the fee-for-service aspect accounts for the minority of services delivered. So, and then the other service categories, by nature of their delivery, we felt that telemedicine is sort of rare. So this year, we did not propose that one as a metric. We certainly would recognize the importance of telemedicine as a metric in future reviews where there are services that have a sizable amount of services that are delivered through telemedicine. But that's kind of the reason that we chose to not put that one forward this year.
That makes sense given the list.
Yeah.
So this is Tim. Telehealth and behavioral health services is becoming more and more of a tool being used, especially in the mobile crisis response and in the mental health assistance response. So we would want to make certain, I would think, that behavioral health services codes and services do apply to mobile crisis and mobile mental health, behavioral health services, substance abuse, and so on. So telehealth is a big component in mobile crisis response.
Yeah, for sure. And while we would certainly want to consider that one as a component of reviewing behavioral health. Again, just our thought behind it with the fee-for-service behavioral health services as opposed to the capitated behavioral health benefit is that the numbers we get back if we were to look at telemedicine as part of the fee-for-service behavioral health part of the analysis, they might just be very skewed. I think that it might not lend credit to the situation surrounding the capitated behavioral health benefit because the numbers of fee-for-service claims are so small compared to the normal method of delivery of behavioral health services. And if there is a desire to still consider that in our analysis, just so we can cover that base for behavioral health fee-for-service, we can certainly discuss that too. Any thoughts to that, MPRRAC or HIGPUF?
I know there's quite a bit of telehealth that goes on in what we call behavioral health, but maybe not what we're talking about with this group. When we talk about substance abuse, things like that, a lot of that stuff is inpatient. But we have there's a large group of people that are accessing Medicaid benefits and using that for their medication management, psychiatric stuff, ADHD and things like that. I think those claims, I'm not sure they go in necessarily and file into behavioral health because I think they show up as physicians type stuff. But if HICPUF, if there's a claim indicator or something that would indicate anything where we could see how many telehealth and how many aren't telehealth going forward in the future, I think that's a worthwhile exercise.
Ling?
Actually, for the behavioral health, we plan to have an internal discussion with our policy people I think about the access to care for behavioral health. If we only apply to the fee-for-service, that's too screwed because it's very limited, under 5%. And if we needed to include both fee-for-service and capitated behavioral health to see the whole picture, I feel it's better to align with the reality. I want to know how the committee think.
So are you saying that we would look at the rates across both or just include the entire service when considering something like the utilization of telehealth across both?
For all access to care, if you want to see the whole picture for the whole Colorado Medicaid program for behavioral health, maybe we should include the capitated and the fee-for-service. Because if you only focus on the fee-for-service, it's under 5%, the utilization. And maybe the result will be opposite to the reality.
Right. Tim?
One of the reasons why I think the fee-for-service may be so low is because in a lot of rural areas, there's not a lot of behavioral health services available, readily available, which is why we're starting to deploy more and more mobile crisis teams and more mobile behavioral health and substance use disorder services. And right now, that's not a payable benefit for a lot of these providers. So you might see higher utilization if they were both included. Thank you.
Yeah, I think that's true. Probably just paints a broader picture and makes it easier to accurately answer that question as well.
I also just wanted to add that in many of the instances where a claim is paid under fee-for-service for behavioral health, it has to do with retroactive ability, where the member wasn't necessarily assigned to array at the time of service. So in many of the situations, it would normally have been paid under the cap had that member been assigned to array at the time of service.
Great. Any other thoughts about access to care metrics? Do we want to keep these as suggested? Are there others in addition to telehealth that we might want to request? So sort of sounding like there's general support for this recommendation and potentially including data on telehealth utilization or accessibility where available. Are folks comfortable? Can we vote to approve these access to care metrics?
Yeah, I'm fine with that. So moved.
And second.
Okay, all in favor, you say aye.
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 Great. Any opposed? Perfect. So we'll accept these access to care metrics plus telehealth when available.
Thanks, Megan. Good work. Okay, continuing on this theme, we have some topics here or data sets that the department is interested in exploring with you all. In some cases, we've shared this information in the past, and just want to walk through it. This information is not always available, but the department would like to explore these areas. So we've seen the top 10 code list for utilized in the last year, and that's been helpful, I think, for a lot of folks to sort of see what are those heavily utilized codes. And some of those outliers, we talked about the outlier analysis where that might apply sometimes. And then the benchmark ratios, we've talked about those here as well. Access to care results, we just talked through those. And then the benchmark rate calculation information, where the benchmark rates come from other states. And this is interesting as well, but the pre and post analysis for the 2023 rate increase and the impact on some services. There have been times when you all have asked things like, well, what happened the last time this was up for review? What was relevant at that time? And where do we stand, sort of as the next review cycle in 2026 versus 2023. So just to put those out for discussion, I think you're familiar with many of these already, but want to, in addition to these, are there any other improvement ideas for 2026 that you would like to explore? I'll always put that caveat out there of, if there are limited resources at the department to do some of this work, but we definitely want to hear from you all in terms of ones that may have be extremely valuable for your analysis. Oh, let's go back for a second. Sorry.
I'll share. I was really happy with the information that we had available this year. I think there was lots of relevant information that was helpful, and I'm also a little cautious about adding too many things in and just having too much information that makes it hard to make a informed decision with really what is most relevant. So again, I think the balance was pretty nice this year.
I would agree with that. The information that we were given was enough to really look into various areas. And when we needed additional information, the team that was on the call was always able to provide that. So I would agree with Megan that we don't want to murky the waters with a lot of additional data that's just going to tie us into additional weeds.
I would agree with Megan and Vanita, and in particular, I've really enjoyed the top 10 codes tables. I think those are very, very helpful to get good decision making. I think we have a lot of information. The packs are pretty long. I don't think we need to be adding a lot to it. Overall, I think, yeah, we're getting really good information. So we just echo that.
Excellent. Any other thoughts?
All right. Thanks, everyone. So we'll, again, where possible, continue providing these, although, again, sometimes they're limited in nature. So continue on the path. All right. The next slide, please, Kevin. So now we move into our training and resources section here for today. This is required training, if you will, per the statute. So for all of you who know this information really well, I will apologize. We do have to review this each year per the statute. All right, so first up, we have some new resources that we'll be adding to the shared 2026 calendar. These are not in today, although I think maybe one or two are, but certainly by the end of November, this folder should be complete. And what you'll see in here are the Sunshine Laws overview. This was a recorded session, if you recall, from a couple of years ago, or actually last year, that was really helpful around what do the Sunshine Laws cover, what do we need to think of as a committee. And then we have our 101 fact sheet. We have the actual Senate bill 22236. That's our law, the MPRRAC law. We have the member term information, some annual training slideshow details there, the new CMS rule, resource links, and then the other normal information that we've had. And then the question for you all is, would you like the department to supply any specific trainings for next year? I'm hearing none, seeing none.
Yeah, I can't think of any in particular unless we end up with certain code sets that have somehow different dynamics that we need to speak to specifically. So whether like in those dental services or others. But I don't think I have any general training recommendations.
I agree with Megan on that. There have been a couple services where the department has provided additional like specific training that's been helpful. So continue to do that where you all think that would be helpful to provide that context.
Yeah, and being a newer member, I got to say the department's done a great job, I think, in just providing that kind of extra detail in some of those areas where we get off into the weeds. So I don't know that we need anything specifically called out other than keep up the good work.
Thank you for feedback. We make a decision. Sometimes we think it's a brief introduction during the March meeting. It's helpful. We will continue to do. If we think we need more deeper training, we can. We did it for the 2024 review. We can make the recording and share with you, because HCBS is very challenging. So we need a deep training. So we did. Same as for the 2026 review. Yeah, we will use a flexible approach. Thank you.
Yeah. All right. So again, in March, if there are areas that look to be a little murky for you all, or you want some additional primers on those, let's ask for those in March, and then the department can respond maybe by that June, July meeting. Okay. Some reminders here of our terms. So we have 3 of our members who are appointed by the governor. A couple of those are going to end next January, so just over a year from now. So Megan and Vanita, and then Chris, you'll be up for a number of extra years there. And then Tim, you'll be on that same cycle next January. Ian for another full year after that. Terry, as we've said, her seat is to open soon, so more details to come on that. And Catherine will end in and Kate will end in January as well. So the point here is, you can see there's 5 of us on the team, or sorry, 4 specifically for next January. So be thinking about, the potentially your peer set or others. Certainly every member can serve additional terms. So if you're enjoying this and want to stay on, we want you to continue to make that clear early on, so we don't begin just some kind of a search or something. But that would need to be reappointed, but can be. So want to make that point, and we're glad to have the team we have. Okay. We just brought this. This is a little inside baseball, but it's worth just mentioning here. There is a new CMS rule around access. There's some complications here, but if you read through the details, essentially the new rule requires states to compare their fee-for-service payments rates for these sets of services: primary care, obstetrical, gynecological, and that list in the first paragraph, to Medicare rates, right? So there are some specific areas where that's required for fee-for-service. The second paragraph emphasizes, these requires states to establish an HCBS advisory group for direct care workers, beneficiaries, authorized representatives, and other parties to meet at least every 2 years and advise on and consult on payments rate paid for personal care, home health aides, homemakers, and habilitation services. And then the third paragraph emphasizes there's requirement for states to demonstrate access sufficiency through an initial analysis to check if under 80% of Medicare rates, or if more than a 4% reduction of benefit category per year, and if the access to care concerns when submitting a state plan amendment with a rate reduction or a restructuring. If not meeting those conditions, the state needs to perform an additional analysis. All right, so as I mentioned, much of the training that we're doing today is actually required per the statute. So, as we work through this. There's a review of the annual review schedule and recommend any changes. We've started that process today. We're reviewing the analysis on the provider rates provided by the department and feedback. And then in conjunction with the department conducting the public meetings as today to allow stakeholders the opportunity to provide feedback. Then the recommendations to the department and the Joint Budget Committee of any changes to the process for reviewing rates, including the measures and increased access. So as we've discussed today, and providing other assistance as is requested by the department. And we do have some specific policies as a result of the work. We have, for example, the meeting will be jointly facilitated by the department's rate review stakeholder relations specialists, our chairs, and GPS for this period anyway. The meeting dates and the meeting materials will always be publicly posted once scheduled with at least a week's notice in advance. The department will share those analyses and conclusions and recommendations with the committee and the stakeholders. Annual training like today will occur. And if an actual, apparent, or perceived conflict of interest exists, that member should disclose such on the basis of the conflict of interest to other members and the public before begin discussing, and as soon as it's been identified. As members, you are held to high standards for your role in working with the department, and that includes participation in 3/4 of all of our meetings. We know people are busy and it's challenging to get through this sometimes, but we really love to have you here. It doesn't work without that. Access to the internet and email communications and so on to receive and review resources is necessary, and audio technology to in a quiet room environment. Prepare for these meetings by reading all the materials, a sense of professionalism and respect for others, and any disclosures of those conflicts of interest that we mentioned. So for our training here, we have operating within limits and understanding the goals. The Colorado Revised Statutes state what each board or commission can do and what authority those members have. We have our meeting etiquette. We've been wonderful in this area of honoring the agenda, identifying yourselves, collaborating, honoring and respecting everyone, and adhering to the overall rules of governance that we covered earlier today. Importantly, particularly when it comes to our public comments, we just really want to emphasize protected health information. So this is a challenge sometimes where we do receive comments that reference individuals or their conditions. It's very difficult for the department to potentially remove that information from the recording and have that still be a coherent flow, depending on the back and forth around that. So individual information just related to the past, present, or future health status of anyone should be protected and not referenced in this meeting. This would include, for example, diagnoses, test results, prescriptions, any identification numbers, birth dates, genders, names, anything like that. We need to make sure that we do not share that in the public forum. Otherwise, we have to try to scrub that, and it can be confusing or difficult to navigate. And of course, then you've shared it anyway for those listening. So we're going to warn everyone as we get into the public comments. As always, please do not reference any specific individuals or conditions as we work through the work. Reminder that the Colorado Open Records Act and open meetings laws apply to our MPRRAC trainings, to our MPRRAC meetings. And basically most public records related to our work are available to the public as in the spirit of open government. So the open meetings law, which is part of the Colorado Sunshine Law, generally requires any state or local government body to discuss public business or take formal action in the meetings that are open to the public. For more information on how this pertains to us, you can review that that training we referenced from last fall, which is really good. There's about 12 minutes in there from the 4-minute to the 16-minute mark on YouTube, which we really love and really nails what we need to be able to think about. All right, so evidence-based processes, stakeholder and member feedback here is very important to the process. The department works to validate all the feedback through data and subject matter experts, unless anecdotal feedback is accompanied by data-driven evidence. That data-driven research conducted in the rate review process is useful for, as we said today, for example, identifying outliers, any repricing methodologies, living cost adjustments when compared to other states, utilization attached to TPL copay reaction to reflect the actual expenditures, and rate comparisons results with the in conjunction with access to care metrics. We covered this at the top, but just a really quick reminder, you know, our first meeting in March, we share that preliminary data and we get feedback from the public and from members about that initial data. By June and July, we're getting deep into the details and any supplemental analysis. We're getting recommendations on each of those services, and we're getting feedback from the stakeholders on that. By August, we've refined that and we've developed our fiscal impact and getting feedback on that. And then our November meeting, as you're seeing, right, additional lessons learned, anything about the next year's services and our training. Okay, any questions on the annual training? Y'all are up to speed again, certified for next year. Okay, thanks everyone. All right, so just some additional training on the benefit determination process. Some questions around this. What is it? We implement the determination request policy in the Colorado Provides CRR. This is an internal process used to evaluate potential changes in the coverage of a Health First Colorado service. This is conducted by the department policy specialists. Other department staff are included as necessary. And this really occurs when providers, members, stakeholders, staff, et cetera, request any coverage changes. So the steps for this are a benefits request is received. The department analyzes that for feasibility using the criteria outlined in the 10 CCR 2505. And then the department notifies stakeholders whether that can be implemented. All right, meetings. So we've talked about this, but so our meeting schedule, we try to get that first meeting in the year in 2026. We'll try to get that scheduled before the end of March. That will give you sufficient time in April and May to review the materials, to become up to speed, right, and to work through what the department has produced before we get to those June and July meetings when your recommendations start to settle in. If we wait too long on that, that really compresses the time frame for that second meeting. As before, we're going to automatically schedule 2 meetings for June and July. We've learned over the last few years that 1 meeting just simply is not enough time to review in detail with all the material we have, all of the services that are up. Even with some of the rescheduling and so on last year, we struggled to get that done in 2 meetings. So we're really interested in getting that. And in particular, we'd love to have that done within 1 week of each other. Sometimes we might be 2 weeks out. This year is particularly tricky. I'll just note with state and federal holidays in the mix, the 4th of July and Juneteenth and a couple other things, the calendar really did not work in our favor. Some of those falls on Fridays. So it's a little tricky this year to try to get two just week over week. So we may have to look at be a little more flexible. We're going to release some potential dates to y'all and hope that you can agree to those this month. But just be as flexible as you can during that period, because we are limited basically by the holiday schedule more than anything for that second set of meetings in the summer. The third public meeting in August, as always, and then finally that November meeting. We've worked on our side to figure out some possible dates that would work, and we'll share those after this meeting with all the members. So. All right, so we've been clocking, as you all have been talking this year, what are some of the potential areas of improvement for 2026? And we've made a number of improvements over the last 3 or 4 years that really have incrementally, I think, made a significant difference in the quality and efficiency of the conversations that we've had in the deliberations of the committee. And yet it seems like we still struggle with a few main themes, including this year. So the first one that comes up a fair amount, and want to have all of you discuss this, should the public stakeholders who asked to speak on certain topics, should we hold that speaker time essentially at the top of the meeting, at the beginning of each meeting? Currently, of course, we do that right after the review of the details on that service category. So you see all the statistics, you see all the metrics and so on. Then you hear from the public, right, immediately after that. And then you can proceed into your discussions and deliberations as a committee. And we've done that because there's so many services and so many details that having that temporally or contiguous to the debate, the presentation of the public feedback, it seems to have helped you all to sort of sort through what is relevant right now for that service category. And of course, we have no idea how many people will want to come in and talk through each category, and we have no idea of the amount of deliberation you would have on any of those. So it's been difficult for us to calendar or schedule, if you will, at 9:30. If you want to talk about this topic, call in or dial into your Zoom. And so that's been really a struggle, right? For some people, we know they log in the morning and they wait for their service category, and they're busy people. They've got kids and jobs and other things going on. So we're trying to understand the balance there. And I would just ask for the committee now to discuss, should we move those public comments up to the front, so making it easier for the public to contribute, if you will, or should we continue our current practice, which may help you all in terms of organizing the feedback and the information and having it in context of that data that we present? What do you think?
I think it's hard. I think it's definitely frustrating for the public to have to wait multiple hours. And then with the 2 June-July meetings, you might wait a full meeting, and then have to go to the next week. But I also find it very helpful to hear the commentary in the context of the service being reviewed. I think that's probably helpful. I find it helpful, and I'd be curious what other committee members think. My other idea was, could we order the presentation by the ones that have the most public comment? Because if you think of this year, I think there were 15 to 20 services reviewed. There were many had 0 public comment, and so the ones that do have public comment could come first, so that anyone who has it doesn't have to wait till the end, and then the ones that don't have public comment could be done later on. That's one idea I had, but yeah, would love to hear others' thoughts.
If I could just jump in on that, Ian, great idea, but it's really hard to order it that way because we don't know, the materials will already be made by the time we know how many stakeholders are signed up for each category. So we would be kind of jumping around all over in the PowerPoint, and that would probably be more convoluted, if that makes sense.
Because you have to post it like a week before or something like that.
Correct.
If you don't have
Yeah.
Okay, makes sense.
Yeah, and we only start letting stakeholders sign up a few days ahead of time, and most of the time people will sign up like the day of, like when we announce it in the meeting and stuff. So arranging it that way will probably not be possible.
Okay, sounds good. Thank you.
Mm-hmm.
I mean, I agree. It's a great suggestion. I think there are perhaps some areas that, we've already gotten some engagement about topics that are coming up for the next year, or there are things that we can sort of pre-anticipate because there's been other involvement. Like, I think that would be one way to make an attempt at it, although it may not be perfect. And I will say, I feel like this year there was kind of an improvement in that stakeholder engagement. I think we gave some feedback in the prior year that it is helpful when, especially in these areas where there are lots of input, that organizations like work together to try and summarize the information and like coordinate and share their information. And I think we had some groups that really somehow got that information, and I think that was really effective. And I think it's important for people to know too that like we are reviewing the feedback that comes through in other forms, whether that's like email or other communications. And I also would love to make it easier for stakeholders to comment, but I think it has been extremely helpful, especially when there are like specific codes or specific concerns or like specific policy changes that would be helpful. Like hearing that in the midst of the discussion, I think we've been able to much more closely incorporate those recommendations as opposed to like hearing it at a different time and then trying to like remember and apply in the same way, or to like have truly kind of comprehended the feedback in a way that makes it easy to relevantly apply.
Yeah, Megan, I would just add, there have been a number of times where I'm facilitating, trying to understand which code sets and which specifics, and we have an opportunity to go back and forth with some of the public, not all of them, but sometimes you ask questions of the public, and then you can do that immediately, right, during the topic and get a follow-up answer or even a third level discussion. That might not be possible if we're just doing their speaking at the very top of the meeting because we don't have all that information yet.
I was going to say something similar, Brian. That's, to me, it's helpful to keep it tied together.
Yeah.
Yeah, and I think, I mean, having a spot at the beginning would be fine, but right away, I'm already anxious about what did they say? Which one was it? Can we get a scribe? Somebody give me some notes. I think public stakeholder, they're allowed to, I mean, aren't they encouraged to also send in email and stuff if they're not able to attend?
Absolutely.
So I mean, I wish that we could say, you're at 10:15, you're at 10:30, you're at 10:45, but it may just be the way the world works.
We did try that years ago, and we never made the time clock.
I can imagine.
Not even close on some days. Not even close. Tim?
I like keeping public comment in the topic area. I think that's the best method for us to keep relevant information during the presentation. Thank you.
Thanks, Tim. All right, I'm reading all the tea leaves here and saying broadly, let's keep it where it is, but maybe there's one wiggle room here. Maybe if there's one topic or two topics that just seem to be dominant for a cycle, and we're getting a lot of conversation around that, there may be a chance to front load those one or two services that just clearly have a lot of discussion towards the front. We'd have to decide that pretty early on, and I'll turn to Michelle again to see if that's even feasible. But
yeah,
that's
I was
something.
just building off of that, Brian, and what Megan said. Like, Michelle, maybe there's a way you can. We just trust your judgment on it. If you all are getting a lot of written comment in advance and are there, like, then you all can choose to move it forward. And if you can't tell, then we just do it in alphabetical order. But I do think that could help just be respectful of people's time.
Yeah.
What do you think of that?
Yeah, I think we definitely can explore that on our end a little bit more and see how we can make that work. Because I do agree. I think everybody on our team will agree as well that we want to be as respectful as stakeholders' time as possible. And like Brian was saying, we know it's hard, to not know what time everybody's speaking. So if there is one or two categories that we know, like you were saying, Ian, that already has a lot of written feedback via email. We can try to see if we can move those to the front, knowing that that's where like most of the discussion will be. But of course, we always want to make sure that every category has, equal amounts of time to speak. So we just kind of have to keep that in mind as well. But as I said, we can definitely take that and look into how we can make that work fairly.
Thanks, Michelle. I'm happy to help with that as well. Okay, good work, everybody. We have another suggestion that came out of a couple of different chats with different people. We're thinking about this. So should the chair or vice chair essentially summarize and write into the meeting chat what the members are recommending as we're getting towards final language on a specific recommendation, like let's increase this by 3% or whatever that might be, or for this code set, let's do this. And so as we're getting through that category discussion, this particularly for the June and July meetings, it seemed that periodically some of you, just had a formulation in your mind of what the recommendation was. You're sort of seeing the true line or the through line of the discussion, and you're sort of summarizing it verbally in some cases, and then there's a change or a wording or whatever that is. So the option here, and this worked pretty well in a couple of cases where one of you just really typed the language of the recommendation into the chat, and then we see the exact words right in front of us. In some cases, we've done that as GPS. We've tried to sort of interpolate what what you're trying to say, and I think we've missed it a little bit here and there. We're not as familiar with some of the terminology or codes. So the idea would be, is that something that a chair or vice chair role should be to summarize that during the discussion, and then and then that is the subject for the eventual vote, for example. I would just add the caveat here is there may be some commas or language and grammar that as that gets finalized that the department or may need to just sort of clean up, but we would be true to the intent and the ethic of the recommendation.
I mean, I think in some of the instances where it's become a little more complicated, like having something written out has been helpful. I will say that I think I personally would have a challenge of like trying to listen and hear the whole story and be the one to do that typing.
Right.
So I'm not sure who would be the right person to do that. I just worry that I wouldn't be hearing everything clearly if I were trying to sort of facilitate and type and summarize.
Yeah, it's a lot to do. That's why we want to talk through it.
Maybe I assume that this is more for the ones that have like 2 or 3 or 4 bullets to it, which is not that many. I assume it's like 80% of the benchmark or 100% of the benchmark. Like that's not that hard. Right. So maybe it could be that if we are in that situation where this is a more detailed recommendation, that between GPS, HICPUF, and the chair and vice chair, we say, hey, like, let's make sure we write this one down. And then either the chair or vice chair does it in the moment. And we just kind of pause to make sure we're all aligned. And we don't need to do it on literally every service. I agree with what Megan's saying. I'm a little nervous of like having to facilitate and write and like do too many things at once. But like
Yeah.
when we're at that moment, then we take the time and we pause and we write it down.
Okay, so we're saying don't fix it to a specific role right now, but rather in the moment where it starts to get a little fuzzy. Maybe it's on me to say this one's getting complicated. Who would be a good person to summarize this theme? And we get a point person on that at that point, and then they go into the chat. Maybe they're the one making the proposal, not necessarily chair or vice chair, but then they're making that some member of the committee.
Yeah, I like having either the vice chair or the chair write it down, and Brian,
Okay.
it'd be your role to basically say, "Hey, I think we need the chair or the vice chair to write
Okay,
it
I got
down."
you. Yep.
And then one of the two can do it. I don't know.
Yeah,
maybe-
I'm happy with that.
Yeah.
I can help. I look to the other members. How does that feel?
I think that sounds like a good process. And I mean, that way members, we can call out and go, hey, we're getting off into the weeds on this. We really should write this down. Which I think
Yeah.
just in my limited experience of the past few meetings, I think we do pretty well anyway, but it's probably good to have just a formal, this is what happens when that happens.
Yeah, I would agree.
Oh,
Me
good.
too.
Yeah, I
Oh,
think it's
excellent.
better to do it in the moment and not have it scripted for all
Okay.
discussions, because I also worry about sometimes we come up with it and then we change it. And so then you've got two different ones in the chat and don't want to mix people up either.
Yeah. Okay, so we'll pay special thought when it starts to get, a detailed recommendation. That's, not one of our sort of standard approaches. I'll pause, ask the question, okay, should we make a specific proposal in the chat? And we'll look to chair or vice chair in particular to lead that, depending on the subject matter and where we are.
Sounds good.
Perfect. Thanks, everyone. We got agreement there. We had a couple other points that we wanted to make here just quickly. Generally, the annual stakeholder webinar, we want to make sure that all members are invited to that going forward just by practice. That hadn't been the case. And then this came up earlier, but we just wanted to state as a formal policy, for example, use of unofficial or individually requested AI notes is permitted, but the department strongly urges the public to refer to the official notes from each meeting that are posted on our website. That's what we suggested today when this came up, and we thought we could just add this to our standard, our rules as we get started next year. I think we're going to be seeing more and more AI note takers, and we go from there.
Yeah, I think that sounds like a good recommendation. I have a question about the annual stakeholder webinar. When does that usually happen with respect to our usual cycle?
I think that is in August or September, if I'm not mistaken. And that's just something that I will forward you all the invite to. And if you are able to join, amazing. If not, we would love to have you, but if you're not available, we all know that you're busy. It's okay, but it's just something that we want to make sure we're at least including you in if you are interested in attending.
Thanks for that.
Can you give us any idea how many stakeholders actually participated in the last one?
I actually don't know off the top of my head. Team, do any of you remember? I don't think I was able to join the last one.
It's more than 1,000.
Yeah, it's a lot.
That's what I
Yeah, it's a
remember. I
lot.
was on it and I know it was over
Okay.
1,000. It was a
Yeah.
big group, and you can review the recordings online too if you missed them.
Oh, good point. Thank you, Terry.
Okay. So just before we go ahead, I just want to say, are there any other suggestions or improvement ideas on our process, on our work together, our documentation, literally anything that you would like to consider before we move off this slide?
I just like to again say that I feel like this year really felt like a significant improvement, and I appreciated the split meeting, and I think we just had some really nice, efficient meetings and really great information, and just very much appreciate that.
You've been a great chair, Megan.
And it has nothing to do with me.
Love that. I'm hearing none. Seeing none in the chat. Okay, let's move forward. Here we go. So a vice chair is needed in 2026. As a reminder, your term would last 1 year. If you're interested, you would essentially automatically roll into chair for the following year. I suppose you could opt out of that and we'd have to start over with the process. But our goal is to have a seasoned vice chair ready to go for the following year, so that some of the prep and post work that we do and all of that is really intuitive when you're in the full sunshine of the chair. So annual election would be today. Do we have any interested parties? Would someone like to know? You're free to nominate someone as well. They do have to agree, though, for the record.
I think Keen and I would both say it's been a really great experience. So
I would echo that. I would say it has not been just a little bit of extra work, but I think it's been overall not that big of a additional lift, and I would encourage others to consider it.
This is one of those where I can't really move along until we get some. So,
seeing no other interested parties, I would submit my name for consideration.
Oh, yes. Thank you. All right.
I would second that nomination. This is Tim. I have served in those 2 roles previously. So I would not think I'd be a good fit.
All right, we have 1. That is the minimum required.
all right, yeah, last chance to throw your name in.
There you go. Thanks, Megan.
All right, and hearing none, I think we can take a vote. All in favor of Christopher taking on our role of vice chair for 2026?
Aye.
Aye.
Aye, yeah. Congratulations, and thank you so much for your willingness to take on the role.
I appreciate the vote of confidence, and I will try not to do too much damage.
Thank you.
You have many in support of you. Believe me, we all want this to be a great committee. So if you ever have questions or concerns, let us know individually or otherwise. We will help. Thank you. All right. I have a proposal in my private chat to take a break for lunch here. We have a couple more sections to go, and then at this point we have 13 public comments. So that may take a bit to run through. I'd look to my chair and vice chair. Do you agree that we would take a break before then, or would you want to just sort of power through the next section?
I mean, I think our aim had been to try and do our lunch break around 11:20, and so I think if we have a fair bit more to go, that this is likely a logical breaking point.
Okay. So, in our practice, what have we taken? Was it 20 minutes? Let's say 20 minutes.
20 minutes.
Yep. So what if we break now and everyone returns at 11:30 sharp?
Great.
Sounds good.
Thank
Right,
you.
we'll see you in 20. Thanks, everyone.
We'll let more stakeholders join. We had about 57 before the break. We're at 45 right now, so hopefully we'll have some more people hop back on. Let's just give it one more minute and then I think we can go ahead and get started.
And it'd be helpful if MPRRAC members can just turn on their camera at least for a moment, or let us know that you're back, just so we can confirm that we have a quorum too. And I think we're there.
Okay. Still, okay. Sorry. There's a lot going around these days. I'm staying out of it.
It's okay. It's just nasty. Yeah.
All right. Well, let's dive back in. We want to respect everyone's time. We have an important section here on stakeholder engagement that we want everybody's input around. So if you recall, a year ago, we talked about making a press into constant contact and being really thoughtful about our outreach on the public meetings, particularly with providers who are relevant to the services that we're reviewing. So this is a practice we intend to continue this year, but we can only reach you if you let us know who you are and what your email is. So the first step is to get that email into the system, and then we can make sure you have plenty of advance notice and can participate. And we'll continue the outreach to providers through the start of the review cycle to gather insights into the services for 2026. So please, if you're involved in any of these services, and there'll be plenty of channels and other ways to reach out to folks, but this is just one more way we want more providers participating in this process. All right, so just a little debrief, right? You may have been aware that there were two specific work groups that we facilitated this fall, and related to PBT and dental. And these were challenges, these particular services, because we don't have the Medicare benchmark world to use as any kind of a guide. And so both of these categories had considerable engagement in 2023, and there was a lot of interest in benchmarking around that. So it was felt it needed to do the department, wanted to do something particularly around these two. And it was a very interesting process. So let's debrief how this worked out. First up on PBT, we had about 30 attendees for each of 3 meetings over the course of it's about nine weeks or so. And we offered to collaborate and select sort of 9 provider-approved benchmark states. There were other states that were involved and had various challenges, whether that was geographical or policy-based or other scenarios that just didn't feel like a good fit for Colorado and the circumstances and the policies that we have here. So we did settle on those 9. There were a number of sort of feedback and analysis concepts there that were shared back with the department in terms of, what's the correct approach to take when states do not perfectly align. So how can we compensate, if you will, for some of the challenges presented by the circumstances that other states have? And then certainly got feedback that commercial rates could be useful in some cases to be part of that benchmark, although there are certainly challenges as we've highlighted today. On the dental side, we had about 10 attendees for each of those meetings. For the DIDD, the Colorado Medicaid plan was a benchmark. And for the state dental plan, we had the dual benchmark methodology there with the APCD dental average commercial payment as one of those. And one final feedback was received around the benchmark states. So broadly, I think this is a really rich and I would say time-consuming, maybe resource-consuming from a department perspective. They really want to invest in these. I participated in particular with the PBT one, but I felt like there was a lot of outreach, a lot of homework that was assigned, and a lot of back and forth to get to the feedback that we did get, and really helped to distill some of the key feedback and found some common ground.
Just briefly there, Brian, thank you all for doing that. I'm glad we did that. Can we make sure that any like as we get ready for the March, April meeting, that any like PowerPoints or anything that are related to this or whatever you think is the right summary is like in our folder so we can take a look at it?
You bet.
Thanks.
I'm sure we can do that. We didn't really talk about this as a group, but I would just say, I mentioned the heavy lift. There are probably some areas that also would be nice to be able to do this, in this next service set category and going forward, right, over the next years. But it is a particularly challenging way to get at this. So one of the things we'll be thinking about is there other ways to get this kind of feedback in a more streamlined manner, but still have the rich back and forth, because it really was the back and forth that helped to get to some kind of a list that we can work on. So I'm probably a little over my skis on this, but I know the department is interested in doing this kind of work, but is limited by some of the resources. So look for them to do the very best they can in this kind of outreach, and try to use the resources efficiently. So, okay, we can keep going. As far as the tariff, if you recall, I believe it was in our March meeting, we shared the survey around potential tariff policy impacts on particularly, I think, durable medical equipment, and maybe a few other areas. The department is essentially unable to repeat that this year. And of course, everyone knows that our tariff policies as a country are in flux and far from being finalized. So what we were asking folks is, to the extent that you believe the effects of tariffs are impacting your services or ability to serve, we would like to know that. So please communicate to the rate review email listed here, HICPF_rate review. If you have information, data of sorts that are saying, hey, this is coming through, if you will, on the business end, and you want to share that with the department. The department is interested in that, but just unable to conduct a full survey again as was done last. Okay, a couple other areas to dive into in our miscellaneous. So first up, we do have an open seat, as has been mentioned, after today with Terry. Thank you, Terry. As has been said, you've been amazing to work with, and you are a loss to this committee. And so we're hoping to find someone equally as talented and fun as Terry. It'll be tough, but we know there are some really good docs out there, and we would love to have this. So we have an application now open. This is going to be posted on the website by the end of November. And the department may conduct interviews with potential candidates, and we're really needing that person to start in March of 2026, right? So that they can get through some of the initial materials that they would have missed today, for example, the training, and then jump right into the March meeting with with the fire hose like the rest of us. So working to get names into the pipeline. Most of those terms, as we mentioned, the bulk of our terms here today with this committee are going to end at the end of next year. So we're still looking for more members. Spread the word. If you know of somebody who would be really useful and a great collaborator in this space, we would love to hear from them over the next year. And we don't want to be in a position 12 months from now, sort of rushing through. We really want to be thoughtful about this group. So we'll probably remind you at every meeting throughout the next year just how important it is to find new talent for our group. So, Michelle.
Yeah, and just to add, members can serve another term if you're interested. So I don't exactly know what that process looks like in terms of like reapplying or what, but we can figure that out on our end. If you are interested, please let us know the moment you know, so that way we can plan how many open seats that we will need to fill. So yeah, thank you.
Yeah, great point. Mentioned at the top. Please stay on if it suits your world. We would love to have that. Okay, let's go ahead and get started with comments from the public.
Yeah, I think Kevin Martin, if you want to jump in to discuss what we had talked about earlier.
Yeah, we just had, preliminary comments come in, and I wanted to level set before we get into this about like what has already happened, what we have control over, what we're talking about here. So really, what we are talking about is for the next year's MPRRAC review, which will lead into recommendations from the committee and then recommendations from the department that then go into next year's budget cycle, potentially for July of 27. I know that there's been a lot of changes here in the recent past, just due to the budget constraints that Colorado is facing right now. I will say that the amended executive order that came out recently, that does that is in effect until the end of the fiscal year. We have no control over that whatsoever. And then as far as any of those things continuing into next year, that's already left the department's hands, and that's now up to the General Assembly, and I guess eventually the signature by the governor. So again, we don't really have any control over that. Obviously, we are often asked for input through that process, but as far as like actually feeding into it preemptively, that's out of our hands at this point. So I just wanted to make that clear for everyone before we get into this. So with that, we can go ahead.
Thanks, Kevin.
Great, thank you.
Yep.
All right, we're going to get started with Ross Peterson.
Welcome, Ross. Can you give us 2 minutes?
Thank you. Greetings. Thank you, committee members. My name is Ross Peterson. I appreciate the opportunity to speak briefly and for your service to our state. I know you put a lot of time into this, so thank you. I'm here to formally request an off-cycle review of the non-emergency medical transportation rates in Colorado's Medicaid program. Can everybody hear me okay?
Yeah, you're good.
Great. Non-emergency medical transportation, or NEMT as it's sometimes called, is a critical service that allows Medicaid beneficiaries to access preventive care and routine care. Without it, many Coloradans, especially rural Coloradans, face mobility barriers and can't reach treatment. Decades of evidence and research show that NEMT is one of the most cost-effective ways for states to improve outcomes and invest in the social determinants of health. As some of you may know, Colorado's NEMT program is currently in a period of significant change. HCPUF is launching a new statewide broker, and at the same time has implemented several emergency measures to combat fraud, waste, and abuse. Either of these actions alone would justify a closer look at rates, and taken together, really make now an opportune time for an off-cycle review. The current schedule has NEMT rate review taking place in 2027. By then, the new broker will have already been operating for more than a year, and the opportunity to ensure success for them and stabilize the system and reinforce the cost control and quality objectives that we all care about will have passed. Earlier this year, the Joint Budget Committee approved emergency rate changes after discovering an actuarial error that applied ambulance level rates to the simplest NEMT trips that was costing the state hundreds of millions of dollars in waste. That correction took place in July and is now saving Colorado over $10 million a month, and we're on track to save $60 million this year just from that emergency rate change. This demonstrates how powerful accurate rate setting can be. However, those emergency measures were not part of a formal rate review, and they did not benefit from detailed actuarial analysis or stakeholder input.
Ross, you're at 2 minutes. Can you wrap us up?
Yep. Please consider a rate review. Now's the time. Thank you.
That was very quick summation. Thank you. Members, we did not have any previous knowledge of this request, I'll tell you. But this is the time for that to occur, this meeting. So I would ask Megan, if you would, we had a section in our meeting today as part of the purpose, which is to consider any off-cycle review request, but we had none, so we didn't bring it up in the agenda. But now with Ross here, certainly appropriate to put that into the committee's discussion. So I'll ask you to ask our members to think about this and provide some feedback, please.
Are we looking to have this discussion now, or would it be in the new business session?
I think we should have it now if we can. We have more public comment to come, and then we would close. So
I'm happy to answer any questions too. I apologize for dropping this on you guys. I learned about this opportunity 2 days ago.
Yeah. Any initial thoughts or discussion from MPRRAC members? Questions? Tim?
Yep. Thanks, Megan.
Being the representing, is that like a double negative? Representing transport services, I would support this, especially since it was not reviewed when we were reviewing other rates. And the other thing is when you think to access the care, that even with secure transport for behavioral health patients, the low cost of the low rates paid by the NEMT program impacts even that level of service. So I would support an off-cycle review of non-emergency rates. Thank you.
This is Terry, and I would also support it. And my basis is our organization has trouble contracting with enough providers in rural Colorado. So I think it's time to look at access.
I would agree with Terry and Tim on that.
It's just some logistical questions. If we do an off-cycle review, does it get reviewed, say, in 2026 and then again in 2027 to end up on cycle again, or does it become sort of a new 3-year cycle?
Up to you. Your committee make decision.
Okay.
Similar to the DIDD, we just reviewed 2025. You want to review again in 2026, along with the regular dental. Yeah.
Yeah, I mean, I think with the DIDD, part of it was that it makes more sense to do as an entire group. I think my other question is just, if we make this decision now, is this the time frame that we can make sure we have a full review? Because I feel like we also did that sort of partial review of some dental services, or just that felt like a little more superficial as opposed to an in-depth look.
This is Tim. Since these rates haven't been reviewed since session before or cycle before, I think it would be relevant to do an off-cycle review, because even if we do that and we recommend rate changes, even when we get back on schedule and it is included in the normal cycle, we may not have any recommendations then. We may continue to support what we recommended I guess the previous year or next year.
Sure. Ling Ling?
Add a context. We reviewed the non-EMT in 2024, but at that moment, because of the full fraud, we only applying the rate-only comparison.
Right. And if we were to do the review for next year, we would be able to do a more complete review.
I hope so. Maybe. Yeah, I needed to check the data. Yeah. If the data, it looks normal consistency, we definitely can do a thorough review.
Yeah, I mean, I feel comfortable with the idea of doing an off-cycle review. I don't know that I personally feel ready to decide whether this would then put them on another 3-year cycle, or whether they would fall back into their usual cycle. And I think a lot of that for me would depend on the data that comes through and if it is more complete and accurate than the review that we were able to complete previously.
We could just kind of punt that second part of the decision till next year when we review the data. Does that sound reasonable?
Sounds reasonable.
Ross?
Yeah.
I don't know if I'm allowed to speak or not.
Well, I'd prefer if you had a question for you, but I'll defer to Megan.
Well, yeah, I'll hear you.
With this new brokerage being implemented, there might be some wisdom in doing back-to-back reviews, because this is a significant change in the program, and it would give you the opportunity to take a bite of the apple twice, 2 years in a row. So for what that's worth, I would recommend doing it 2 years in a row.
Thanks for that. All right. Any other discussion from MPRRAC members or Ling Ling?
I want to check with Ross. Do you say the 2 years in a row? What is the 2 years you refer?
It would be the off-cycle review in 2026 that I'm asking you to approve today. And then as the chair just suggested, the regular review was scheduled for 2027. So those back-to-back reviews would be the off-cycle in 2026 and then the scheduled review in 2027, which I think it makes sense given the changes that are happening.
Okay, thank you. And I want to mention, because we already know the non-EMT, they have a few code has the big change. And as Ross, you mentioned, and that change is effective on July 1st, 2025. That means the utilization data should be very limited. You see now only like 3 or 4 months. So if you do an off-cycle review, the data maybe still has the issue, just like you don't have enough data to show the impact. So if you still want that, I'm fine. And if the committee approves.
Other discussion?
So this is Kate. So just to clarify, we could do the off-cycle review, but we might just not have the best data. Is that what you're saying, Ling Ling?
Yes. Maybe we can only have like a half a year data for the new rate.
Yeah, that would be for the the following year. An off-cycle review would have complete data. It's still a bit questionable about exactly how reliable that is, because the fraud issue did persist for a while and it was still being cleaned up. But we can use it. There'll just be like a caveat on there that the utilization might still be a little bit funky. It won't be as bad as when the fraud was like ongoing, but it's still going to have some issues left in it. But as far as like if you do the second year review, it's not going to reflect the changes from the prior review or from the off-cycle review. Hopefully that makes sense.
Yeah, I think that makes sense. Thank you for that. Other thoughts from
So,
members?
so
go ahead.
that means if you want to do the off-cycle review in 2026, that means first, probably the data is not very solid there for the new change. We probably need to have some like processing, you do some proxy estimate to show you suppose it's not the real actual data. And in addition, probably for some code, maybe we think it's more applicable to use rate-only comparison. And for the non-EMT, they have many code, the majority code have no Medicare rates. So it's come from other states. We need a heavy provider engagement to develop a solid benchmark steadiness. Yeah, I just share what I know at the moment.
Great. Thank you for that. So I heard a fair amount of support for considering this off-cycle review. Any other thoughts or other opinions? Otherwise, I can accept a motion.
So I would move that we do an off-cycle review of NEMT rates.
And I would second Tim's motion.
Great. All in favor, will have you say aye?
Aye.
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 Any opposed? Great, thank you. We will look forward to hearing more next year.
Yep.
Thank you.
Apologies for the the abrupt notice. It would be useful in the future for everyone to give us a heads up a little bit earlier. So appreciate that. And I know you just learned about it, Ross. You shared that, so nothing on you. All right.
And, just real quick to clarify for everyone what the rest of the process looks like for off-cycle review is that
Thanks, Kevin.
The department does have 30 days to respond with any things that would be preventative of doing that. I don't really see anything from our perspective, but we are not the final deciders. So I just don't want you to be surprised if there is something that comes out, but I don't see that as, I am not imagining any issues with that off the top of my head.
Thanks, Kevin. Good caveat. All right. Let's move forward with additional comments from the public.
All right. And just as a reminder to everybody, please make sure not to share any PHI in your comments. So we'll take Kevin Patterson next.
Kevin, you there? 2 minutes, please.
Great. Can you hear me?
Yeah, go ahead. You've got 2 minutes. Thank you.
Excellent. Thanks. I appreciate the opportunity to speak today. I'm Kevin Patterson, oral surgeon in Denver, Colorado, and the past president of Colorado Dental Association. I'm speaking to the upcoming rate review benchmarks that's being set for dental. I know some of that was discussed today. I just wanted to reiterate in conjunction with some written testimony that I submitted, plus a table of states to review that CDA submitted in detail. Colorado has built one of the strongest adult dental Medicaid programs in the country. Reimbursement levels now are well above the national average, and meaningful growth in provider participation, especially among some colleagues like endodontics or root canal specialists. These are gains that have happened because Colorado invested in its rates based on real cost of care data, and we cannot afford to move backwards from here. So we're asking, as you consider benchmark methodology, to consider the most accurate and Colorado-specific data source, which is CIVIC, which we've spoken to before. The dental claims dashboard, it reflects true market cost of providing dental care in Colorado and is the closest equivalent we have to the cost-informed approach that Medicare uses if Medicare dental fee schedule actually existed. Looking to other states is risky unless you know how these states set their rates. Many do not use cost-informed methods, and some provide only emergency level adult benefits. So benchmarking Colorado against low benefit or low investment states would create an artificial floor that can harm access, particularly for our high need adults rural communities and for specialty care. So if comparison states must be used from the table we suggested, looking to Missouri, Delaware, South Dakota, Ohio, Michigan, Montana, Wyoming, Oregon, Massachusetts, Vermont, and Alaska. And this table was submitted by CDA. So I want to reiterate that we have made real progress, and to maintain access, stabilize our workforce, meet statutory requirements for rate adequacy, we have to use benchmark methodologies that are grounded in transparent, Colorado-specific, cost-informed data. The Civic
Kevin, you're
dashboard
over 2
gives us
minutes,
that.
please.
Thank you. So I just ask you to look at the Civic dashboard. Thank you.
Thanks, Kevin.
All right. Next up, we have Josh Pritchard.
Josh, you there? Josh?
I don't see them on the attendee list.
Going once, Josh. Twice. Okay, next.
Will Martin.
Hi there.
Welcome, Will.
Can you hear
2
me?
minutes,
Okay?
please.
Awesome. Thank you. I'm here today representing the Colorado Association for Behavior Analysis, or COABA, who represents many pediatric behavior therapy providers, or PBT providers in the state. I wanted to draw to MPRRAC's attention that PBT recently received a rate cut from Governor Polis and HCPF that was done outside of the MPRRAC process. This rate cut was disparate and more than what other services received. And it also included a new benchmark that was also not included or conducted as part of the MPRRAC process. The impact of these cuts has been substantial. We've already seen the impact of unsustainable rates in Colorado. We just had an emergency rate increase, and prior to that in 2023 and 2024, up to 9 agencies closed in the state, which really limited access to therapy for kids with developmental differences. So COABA is urging MPRRAC to consider this information as you are reviewing PBT in the upcoming year. As you could tell from our participation in the provider work groups, we believe deeply in this process and respect the MPRRAC process quite a bit, and are urging you to consider this information as you're reviewing our service in 2026. Thank you for your time.
Thank you, Will. Next up.
All right. Next, we have Alexandra Tomai.
Welcome, Alexandra. 2 minutes, please. Alexandra? Don't see her online.
Yeah.
Going once. Twice. Okay, next.
Hey, Jonathan Mueller.
Jonathan, you there? 2 minutes, please.
My name is Jonathan Mueller. I'm a co-founder and co-owner of Ascend Behavior Partners. We are a proudly independent, locally owned pediatric behavioral therapy agency. I'm here to share my concern about the governor's off-cycle rate reduction for pediatric behavioral therapy, and to enthusiastically support MPRRAC's important role in providing rate and benchmarking guidance and recommendations to the JBC. You know, at Ascend, our mission is, our vision is transforming lives, and our mission is building strong foundations. We work with vulnerable families living with autism day in, day out. We provide comprehensive diagnostic evaluations and in-home and center-based ABA therapy and wraparound family mental health support. What parents tell me all the time is, Jonathan, when they get a diagnosis, they say, Jonathan, I'm going through a grieving process for the child that I thought I had. And it is our firm belief that these families with Medicaid deserve the highest quality treatment. And so we're doing everything from helping them go to the bathroom for the first time independently and on their own, speaking, verbal or nonverbal communication, whatever they're able to do to say, I love you for the first time to their families. Unfortunately, we have had to take a variety of cost-cutting measures over the last few months since the governor's executive order, including reducing our admin staff, including putting on hold searches for a larger space so we can serve more members with Medicaid. And so just to wrap up and emphasize, these are important and vulnerable families and individuals. They deserve the best. And rate cuts and benchmarking changes that happened outside the standard MPRRAC process make it very hard for small businesses and agencies like ours to plan and invest in the future, and most importantly, invest in these families. Thank you so much for the public comment.
Thank you, Jonathan.
Thank you, Jonathan. Next up, we have Amanda Mellett.
Amanda?
Hi, everyone. Thank you so much for your time today. I actually am here on behalf of Action Behavior Centers, and my comments will be similar to Will's and to Jonathan's. This last fall, PBT faced major challenges when it was singled out for revised benchmarking outside of the standard MPRRAC review process. And these changes have directly affected the children and families that actually rely on PBT services, which has also resulted in disruption to access to care and added additional strains to an already vulnerable population. These consequences are pretty clear. In 2023 and 2024, 9 PBT agencies in Colorado actually were forced to close due to the financial pressures that previously ensued. And we're experiencing the same thing now, again, because determinations were made outside of standard MPRRAC review and, of course, JBC decisions. So I think the things that we just ask MPRRAC to look at is to set an appropriate benchmark and restore reimbursement rates to sustainable levels so that providers can remain open and children can continue to receive the support that they need. Thank you so much for your time.
Thank you, Amanda.
Thanks, Amanda. Lauren Harvey.
Welcome, Lauren. 2 minutes, please.
Hi, thank you so much. Can you hear me?
Yes, please go ahead.
Good afternoon, MPRRAC members and staff. My name is Lauren Harvey. I'm the Director of Government Relations at the Colorado Dental Association. Thank you for your time today and for your important work on Medicaid and ensuring that Coloradans have access to Medicaid services. This group is integral to ensuring that our Medicaid program is strong and robust with your data-informed reviews. I did want to share feedback from our Medicaid dentists on the 2026 Medicaid dental review, which you also heard from Dr. Patterson about. We have shared this feedback with HCPF and do appreciate HCPF's meeting with us to review and engage on the 2026 review. Quickly, in 2023, when there was a small partial review of dental rates, the MPRRAC recommended using a dentist fee survey from the American Dental Association as a benchmark. The fee survey was indicative of cost of care and did help set sustainable fees for a select set of Medicaid dental codes. And thanks to the work of the MPRRAC, that led to an increase of over 180 new dental providers enrolling in the Colorado Medicaid program in just a 6-month timeframe, which greatly increases access to care. The ADA no longer conducts that survey. However, as you heard from Dr. Patterson, we now have a great new resource from the Center for Improving Value in Healthcare, known as CIVIC, with the dental claims dashboard that is publicly available online and shows Colorado-specific dental claims from commercial payers for nearly all dental codes. Because a benchmark is a reference point to judge what is the typical cost to receive a given service in the free market, the CIVIC Claims database is the most accurate and comprehensive benchmark of dental fees for Colorado. We also provided feedback to HCPF about using other states as a benchmark, as you heard from Dr. Patterson. Overall, we want to note that we do not believe that using other states is an appropriate benchmark or useful for increasing access to dental care. Our biggest issue is that HCPF does not know how other states set their rate methodology. So if states are just benchmarking to each other, the state-to-state comparison is merely an echo chamber, and it does not set fees based on data and actual cost to provide care. Looking to other states falls short in addressing access to care because it does not use data to work toward an adequate provider network. We would highly recommend using the CIVIC Dental Claims Dashboard because it's cost-based and is Colorado-specific, and that was what we would like to see for the 2026 dental review. Thank you for your time. I'm happy to answer any questions.
Thank you, Lauren.
Thank you, Lauren. Next, we have Jeff Laudel.
Jeff, welcome. 2 minutes, please. I don't see Jeff. Jeff, you there? Going once? Jeff? Okay.
Next, we have Emily Ice.
Emily? You come off mute. Emily Ice? Going once. Last chance, Emily. Okay.
Okay, Jill Hawks.
Jill, are you there?
I'm here. Can you hear me?
Go. Yeah, 2 minutes, please.
Good afternoon. I'm the current president-elect for the Colorado Speech and Hearing Association. I'm also an SLP, a small private practice owner, and a Medicaid provider. First and foremost, just want to thank you all for your very hard work and time and commitment to this committee and everything that you're doing to provide support to the providers in Colorado. I jumped on today. I want to just talk a little bit about our deep concerns with the potential decrease in provider reimbursement rates following the release of the proposed budget for next year. We're concerned that the potential decrease will create confusion and lead to lack of trust in governing bodies, including HCPF, among speech therapy providers across Colorado. And while we are deeply grateful for the work of this committee, we'd also like to document our concerns with the budget recommendation to decrease provider reimbursement rates to that 85% benchmark in a year when this rate review committee has recommended that 4 of our speech therapy codes be increased to 100% benchmark. CASHA, including our members, have put a lot of time and hard work into collecting and sharing the data on how lower reimbursement rates impact the lives of our businesses, our providers, and ultimately access to clients across Colorado. We know the proposed budget is not your decision. We want to highlight that participating in this process feels a little frustrating if the work of this committee and the stakeholders feels like it's being ignored. As we've discussed previously, lower reimbursement rates lead to inequitable and unsustainable practices and ultimately results in providers leaving Medicaid, which is not good for our residents in Colorado. We thank you so much for your time and taking all of these factors into consideration as you present your final recommendations. And again, just thank you so much for your time and work.
Thank you, Jill.
Can I ask this is Kate. Can I ask a procedural question about that? I think we've had that in the past where our recommendations didn't show up in the final budget calculations. Wasn't there in the time past we've noted that like MPRRAC did not agree, like MPAC recommended 100%, but that was not what was presented. Haven't we done that before?
So the amendment to the MPRRAC process that happened, was that 4 years ago now, that created this new 3-year cycle, does require us to include your recommendations, but ultimately the report is the department's recommendation. Just like you don't have to consider budget concerns through your recommendations, that is something that has to be represented through the department and the executive branch.
Yeah. I was just trying to remember if they're represented next to each other, like the discrepancy is represented. I can't remember if that's happened or not.
We do display them right next to each other. So It just says MPRRAC recommendation and then department recommendation right after.
Perfect. Thank you. I wanted to make sure that was the case.
Thanks, Kate.
All right,
okay.
Next, we have Dana Stevens.
Dana? There, Dana? Dana Stevens? Going once? Dana?
Not seeing them on the attendee list as well.
I don't see Dana. Thank you.
Okay, and lastly, we have Bethany Coop.
Bethany, welcome. 2 minutes, please.
Thank you for the opportunity to provide public comment. These cuts are not merely numbers on a spreadsheet, but they target the very supports that keep our children safe, regulated, learning, and living at home. These services are what prevent institutionalization, school exclusion, medical crises, and long-term dependencies. Removing these threatens to take Colorado back to a time when children with disabilities were isolated, warehoused, and denied opportunities to grow into independent, thriving adults. I want to emphasize two central concerns. One, these cuts unfairly target the smallest and most vulnerable minority group in our state. This administration frequently speaks out about protecting minorities in this case. Yet in this case, children and adults with profound developmental delays, individuals with no political voice and no ability to advocate for themselves were selected to bear the disproportionate share of the financial burden. This is not equality. It is discrimination in practice, no matter the intention. The governor's office circumvented the established review process designed to prevent harm. Colorado has a thoughtful system for rate review, stakeholder input, and legislative oversight. These structures are intentionally in place so the decisions affecting life-saving services are not made hastily or without expertise. But this time, the system was bypassed. The Medicaid provider rate review process, the Joint Budget Committee's oversight role, and the public right to comment were all effectively sidesteps. Families, providers, and subject matter experts were denied the opportunity to analyze the impacts or to offer alternatives. That loss of transparency undermines both the integrity of the system and the trust families place in it. So what's at stake? Cutting these services, the therapeutic supports and home health care, does not save money. It shifts the cost to more restrictive, more expensive systems such as hospitals, residential placements, law enforcement, and long-term state dependencies. It
Bethany,
also
we're over 2 minutes. See if you can wrap up, okay?
So my request today is simple. Reverse the disproportionate cuts to disability stores. Try to restore transparency by requiring adherence to regulations and rules, and protect, not punish, Colorado's most vulnerable children. Thank you.
Yeah, thank you, Bethany. I see a text from Emily. She missed her comment, wanted to express. I think we could ask her back if you agree.
Yes, one quick thing here. I wanted to point out that referring to family members is considered PHI in this context. So we will need to edit that stakeholder feedback. We'll try to do that as minimally as possible to preserve as much of it as we can. But there will be at least that portion of it missing.
Yeah, thanks, Kevin. Just another reminder, please avoid any reference to personal health information. Thanks, Bethany. All right.
I appreciate that, Bethany, but it does require a slightly more in-depth process. And so it is not always adhered to by everyone, and to be fair to everyone that tries to provide PHI, we just opt to remove it from our record.
And we did receive a request from Emily Ice. Tim?
Just a quick procedural question. You know, when we discuss this topic, it has personal impacts on individual families. I understand the rule and the HIPAA rule. Is it possible that we can have a HIPAA disclosure, a HIPAA release if somebody wants to testify like that? Because I think it can be impactful on what we do, how we do it, how we consider things. And that would be an additional benefit to families, especially like the last person who spoke. Is that even possible? Thank you.
I can definitely take that back to our HIPAA officer and see if there is a way to do that. We have had extensive conversations about this with them in the past. So I'm not super hopeful that we'll find a good middle ground, but we can definitely bring that topic up with them again.
Perfect, because even if they were to do it before, so they would sign up for public comment and they would sign that document beforehand. Thank you.
Thanks, Tim. All right. Megan, are we good to go back to Emily Ice?
Yes.
All right. Emily, 2 minutes, please.
Yeah, thank you very much. I'm Emily Ice. I'm a board certified behavior analyst at the doctoral level. And I just wanted to say thank you to the MPRRAC members for your time and ongoing work on this complex issue. In the interest of time, I will simply state that I fully support and align with the comments submitted by the Colorado Association of Behavior Analysis regarding the pediatric behavior therapy rates and challenges. And I respectfully give the remainder of my time back in agreement with their statement.
Thank you, Emily.
Thanks, Emily. All right, that concludes all the public comments.
Okay. Next slide, Kevin.
Just a question going back to what Kevin said at the beginning. There's really nothing we can do about these comments at this point. It's more picking it up in the next cycle, or anything else you all would share there.
Yeah, at least for the time period between April 1st and June 30th, that is already done for the executive order that was authorized by the legislature through the special session. And it is into the budget cycle for this year, or already submitted to JBC. So it's not done for next fiscal year, but it's at least outside of this particular process. So there are other opportunities for people to make their case about what should be happening for next fiscal year, but it's outside of the purview of MPRRAC for next year.
Sounds good. Megan, I don't know if you want to include this in your presentation next week, or how you're feeling about that, but I think that's probably the only meaningful thing that MPRRAC can do in the process, sounds like.
Yeah, absolutely. I'll be sure to reference it. I mean, in some way, I think I have comments that are focused on that as well.
Okay. So we turn our attention to 2026 fully at this point. We will send out a survey for meeting dates for the 2026 cycle. And I mentioned that we struggled a little bit in the June-July timeframe just because of the holidays landing on those Fridays. It'll be a little tougher for us to get immediate weekends after another. So just be a little bit flexible on those if you don't mind. Meeting minutes, as always, will be sent to chair and vice chair and then on to the committee. They'll be posted to the website within a week of this meeting. And the summary will be faithful to the recommendations without, and will show any minority opinions if they existed. Just another chance to check out our home website. And contact information, most importantly here, that shared email box, HCPF_rate_review@state.co.us. That's the best way to reach the team, and they can forward that on to the proper experts for any additional information. I'd like to say thank you, and we'll be wrapping up unless there's any additional business.
I had one question, sort of with respect to the surgical codes. I know they got sent out as a group, and there was a request to submit comment about that by today. Is there a best way to do that? I wasn't able to edit that document or add comment on that document. It's just about the groupings of the surgical codes.
Who can help here?
You can still have some time to do that. How about the end of November?
Yeah, I think that's fine. I think I just needed to be able to edit that document because there's a column that says notes, but then the document was view only.
Oh, Michelle, maybe we need to change the permission type.
Yep, I'll do that right after this meeting.
Okay. Yeah, and then I'll get that.
Thanks, Michelle.
In the next couple days.
Wonderful.
Great.
Any other questions or concerns for the committee? Okay.
Yeah, I just wanted to say a big thank you to everyone. Again, I think this was a really great year. I appreciate all the hard work that the department staff put into getting us some really helpful information. I think, again, we had some really great stakeholder engagement and feedback, and it really is tremendously helpful to do this work and do it in a way that hopefully is meaningful and impactful to the providers in our community and the people that the DA serve. And a big thanks to the members and the time that is devoted to putting into this work, and a specific thank you to Terry. We'll miss having you next year, but it has been great working with you on this process.
Thank you. I will miss all of you too. When I saw it in writing on the agenda, I thought, oh no.
This is happening.
Great. Well, again,
all right.
And thank you, Megan, for your leadership as well.
Thank you.
Yeah, you've been a wonderful chair. We're delighted to have you.
Absolutely.
Great. Thank you all so much. I think we're at the end, and we'll look out for that survey for dates for next year.
We are. Thanks, everyone. Enjoy the rest of your day.
Thank you so much.
Thank you.
Have a great day.